Okay, so good morning to everybody. Thank you for joining us. Just a short beginning, a few words. In the room with us is Lotan, our teammate, Dvir, our teammate, and Fabrizio, who is from Qualimed. This morning, we're going to have a short presentation and discussion about the new product that we just had 3 first cases in Israel, within the Middle East as well, of the UnityB stent, biodegradable biliary duct stent. So this short visit with us will be starting with Fabrizio, who's going to have a short presentation on the product itself and introduce it, and then we'll carry on and showing and introduce the 3 first cases that were done just the past 2 days. So I'm going to switch over with Fabrizio with us, and I'll be sharing, and he'll be sharing his screen. Okay, so thank you very much for joining us.
Can you put the presentation?
Yes, sure. Okay. Okay.
I think it's working.
Okay, just present. Okay.
Great. So thank you for the opportunity of to me that you offer to me to share our technology, our great achievement, because it took us many years and a lot of investments to arrive to the last May when we obtained the CE mark for this product. It's not easy to develop biodegradable technology, so a lot of companies are working on it. So we are very proud of being the first having this product, which is a percutaneous balloon expandable biodegradable stent dedicated to the biliary tract. If you look at the stent, it looks like a normal balloon expandable stent. It looks like a chromocobaltum or a steel stent, but it is actually made of magnesium, so it is completely biodegradable. The stent is mounted, it's crimped on a balloon, O35 balloon. The shaft for the moment, because we are really at the beginning, at the first step of this launch, we have 80 centimeter shaft, which is more than enough for the transhepatic implant, and a 10 millimeter diameter, but it's available also on 8 millimeter under request, and the length standard is 57 millimeter. How is it made? It's made of an alloy of magnesium, but 97% of the stent is magnesium, and polymer covering it. It's a simple PGLA. Of course, the secret and the patent is on how do they make it and how they delay the degradation of the stent. At the moment, it's available, the fast degrading stent, so we can guarantee 1 month, 1.5 months of radial force, similar to a steel stent. We give this product for 1-3 months degradation time because it's practically impossible to predict any organism reaction to the stent. But we can guarantee this 1 month, 1.5 months of radial force and the complete degradation of the stent in 6 months. When we say completely, we mean also the tantalum market, because they are made of powder of tantalum, so they also disappear within the 6 months. The benefits, I think I don't need to tell you the benefits. I mean, you can avoid the second procedure, the procedure where you need to recover the stent or replace the stent. You can close the patient after the implant and avoid a second trauma to the patient with all the possible complication and the cost for the administration. In order to obtain the CE mark from the authorities, we had to do a study that was a little bit blocked by the COVID, unfortunately, but at that time, now there are more the patients, but at that time we could collect 37 patients, and we already had 1 year follow-up where we saw 0 adverse events or serious adverse events, and complications that are regular complications considering the kind of procedure. I mean, pancreatitis, jaundice, pain. I mean, that's normal.
Sorry, just
Can you go to another?
Yeah.
Thank you. So the first point was the safeness of the study, and that was achieved. And then we had the clinical, procedural, and technical success, which are very high, as you see. Honestly, technical success should be 100%. Just 2 patients could not be implanted because they could not cross the lesion, because at that time we did not suggest to predilate. So now to predilate is mandatory. And we had 169 follow-up with very good quality of improvement of quality of life. Now the cases are much more, of course, because in the last 6 months we went over, and apart from the initial centers, which are in 3 or 4 in Malaysia, 3 or 4 in Hong Kong and India and different countries, I included the polyclinic of university in Milan, just to have an European centers, and we have a few implants also there. How do you use this product? It's very easy. It's just to predilate, as I suggested, in order to prepare the landing zone of the stent, because some lesion can be very hard, very tough, and to use the stent to crush a hard lesion is not recommended. I prefer to have predilation in order to prepare the landing zone, and then use our system as a delivery of the stent. Then a few things like do not make negative pressure before inserting the stent, and do not touch or wet the stent, because it looks like a regular stent, but it isn't. It's a bit more delicate. What do you need in your catalog in order to implant? Just any 35 035 guide wire, any 8 French introducer, and any balloon for predilation. The point is that we are just at the beginning of this technology. We have this biliary stent that will evolve in vascular, so in peripheral. It will go to coronary, hopefully as a drug-eluting, because we know that magnesium can create a lot of inflammation locally. So, and the following step that a lot of people are asking about the urology, because it seems that it will have a very big impact on urology. So we are just at the beginning. So I'm very proud that we could have this first implant in the entire Middle East, because we are at the moment that we have everything under the bureaucratic part. I mean, the CE mark, all the declaration of conformity. I mean, the work has been done from the company. Now we are going on the field, collecting cases, collecting data, collecting feedback and new experience. And of course, looking for investments for growing and going to the peripheral, coronary, and urology. But the technology is very promising, because up to now we implanted a lot of stents, and all across Europe, because I had cases also in Zurich, Austria, Brussels, Riga, Copenhagen, and we are moving on Spain and Italy. So it's growing, and there is a big request, a big enthusiasm. I'm also organizing a registry that can cover Europe and perhaps Middle East, in order to collect as much information as possible, to put them, to keep them under control, to have potential publication, and to share it with future congresses. So this is the point at the moment. If there is any question from the field, it's open. I'm here.
Let's just see.
Hey.
A second. Sorry. Oh, just a second. I have a way to do it. Oh.
You want them?
I want to.
In participants, perhaps you can add the list. Okay.
And then you just do one by one.
No, they have to unmute if they want to make a question. Yeah. No, we are okay.
Okay. Are there any questions? Somebody wants to? Okay, maybe later. We'll
Can
go
you
ahead.
unmute? And, yes.
Okay.
Anyway, I'm here.
Okay. So our next sharing will be from Professor Bloom from Hadassah and Karem. I will ask you if you can share a bit from your experience that you had with your first procedure this week. And go ahead. Thank you very much.
Thank you and good morning to everybody. Do you want to share a screen? I can show some pictures, or do you just talk about it?
If you can show pictures as well, that would be great. We have some pictures from the other two sessions, so whatever you can share will be wonderful.
Can you share screen?
That's a good question. I'm not sure if I can share your screen, but do you have an option on your computer to do that?
Yes.
From your presentation to Professor Bloom, can you share a screen?
You need to disable your share screen and then
No problem. Okay, that should be doing it. Should be.
Can you see that?
Not yet.
Yes. Yes, okay.
Okay, so the patient that we treated the day before yesterday was a 65-year-old male with a history of hepatitis B cirrhosis. Earlier this year had COVID-19 infection, which he recovered from. He underwent OLT, liver transplantation, in April of 2021. The procedure went well, but several days post-op, he had significant hemorrhage, which was treated initially endovascularly and then followed by that surgically. He also had a subsequent endovascular treatment of an hepatic artery pseudoaneurysm. He developed a bile leak and infection, which was drained with 3 drains, 2 percutaneous biloma drains, and then a transhepatic biliary drain, following a failed attempt to treat it endoscopically with ERCP. The anastomosis that he had was a duct-to-duct anastomosis with associated high-grade stenosis with this biliary leak. So it took us a couple of months to get everything under control, to drain the bilomas and to be able to cross the stenotic lesion. And he subsequently had 3 balloon angioplasties at sequential procedures about 6 weeks apart. But the restricture unfortunately recurred after each angioplasty. So on the left-hand side of the screen here is the initial cholangiographic transhepatic cholangiogram showing the area of the anastomosis with a non-continuity, or what appears to be non-continuity, and a bile leak. As I said before, this was treated by repeated procedures. Several months later, after a previous balloon dilatation transhepatically, this was the cholangiographic appearance. So there's still a high-grade anastomotic stenosis with some proximal biliary dilatation, despite the previous procedure. This was the appearance the day before yesterday on the right-hand side of the screen, showing again the presence of the stenosis. At this point, we have the 8 French sheath in the bile duct and injecting contrast directly. This was the pre-dilatation. As Fabrizio mentioned, we used a 9mm high-pressure balloon to dilate across the stricture. And this is the appearance of the Unity stent after it was deployed across the lesion. You can just about appreciate here the tantalum markers at the top and bottom end. This was the cholangiogram after the stent deployment. You can see more clearly here the outline of the stent, I think, and some passage of contrast to the duodenum. And then the final image we have is the cholangiogram without the wire and with a external biliary drain placed above the stent, which we capped off immediately. It's now 48, 72 hours after the procedure. The patient's doing very well. In fact, I think he was sent home yesterday evening. We're planning to do a catheter cholangiogram liver function test at 2 weeks and possibly remove the drain at that time if everything looks good, and then follow it up with liver function tests and CT at 6 weeks, and probably again at 90 days, depending on how the patient is faring. So that's it.
Thank you very much, Professor Bloom. That was a lovely presentation of your case. It was very exciting attending your cath lab for the first case in Israel. So thank you very much for sharing. And now we would go ahead and the two other cases that were done in Bennington Hospital. So I would start with Dr. Dr. Bendat, if you can join us. Oh, second. Good morning. And I will
Good morning. How is everyone?
Good, thank you very much. And I'm going to just pull up the presentation.
Yeah, you
just
have
a
our
few
pictures, yeah.
Yeah.
So our first procedure was done yesterday morning. The patient was 23 years old, 7 months post living donor. It's rotated. 7 months post living donor liver transplantation. And a few weeks after the transplantation, he presented with a recurrent cholangitis. So, and they couldn't do any RCP because of the Roux-en-Y. They tried, but they couldn't succeed. So we first inserted a PTBD a few months ago, and we did a few angioplasties, including a cutting balloon. But we even tried once to take out or leave him with an external drain. But after a few days, he developed a recurrent cholangitis. So we reinserted the PTBD, the internal and external, and we brought him yesterday for the UnityB implantation. So this is the first cholangiography. It's hard to see because he was very, very well drained with our drain, but there was a stasis of bile inside. Can you make it bigger or something? Are you showing it from a screen? Okay. So you can see that there was stasis inside of contrast inside the liver. And we took, the company said that we should take an 8mm French, but a sheet, but 8 French sheets, sorry. But we wanted to be sure for the first case, so we took a 9, like 1 French bigger, which was very, very easily. So this is the PTA, and you can see where the problem is on the balloon. I don't have the mouse, so I can show it, but I'm sure that everyone are seeing. Right. So after a 7mm balloon, we decided to put the 8 stent, the 8mm stent, the 857, and we inserted it. And this is I think the final. Yeah, this is the final with the after the UnityB insertion.
No, this is the deployment, just a placement of
this is the deployment. Okay, it's very hard to see from, it's the film. Okay, so continue.
And this is the UnityB dilatation. So
this is the UnityB balloon, opening. You can see where the shoulder and where the stenosis is, and it opened very nicely.
The markers.
It was a bit. It was the 8mm was a bit even oversized for his bile duct, for his intrahepatic bile duct. So we didn't dilate it more, and this is the final. We wanted to leave we planned to leave an external safety drain, but because he has like a very, very delicate and very small intrahepatic bile duct, we took everything out. And I was just informed that he was feeling very well during the night, and he was just now leaving the hospital home. And we'll keep on seeing him, in our clinic and in the transplantation clinic on the next few weeks.
Thank you, Dr. Bendat. This case was it was really nice to see this very young patient being treated and hopefully have his improvement in life and be able to walk free with no further
Yeah, we have
restrictions.
many cases like that in not many, but we have quite a few
And
waiting
just
for
to-
the stent, already waiting for the stent. Yeah.
which is amazing to see that to know that we can treat and help so many more people. This is, just for you know, the youngest patient that was treated with the UnityB. So it's also very
Nice.
exciting to be so advanced.
He
with
was
it.
very, very thankful, yeah, for the opportunity. Yeah.
That's amazing. Okay, so thank you, Dr. Bendat. And our next case is by Dr. Belinki. Good morning to you.
Good morning.
And I'll share also, again, just give me a second, I'll share your pictures that we managed to get from yesterday. Sorry. Nope, wrong. Okay.
It's final results.
Yeah, okay. So this is our first screen. Go ahead. Thank you very much.
Yep. This is very complicated cases from women 62 years old after Whipple procedure with many complications due to post-operative period and few pseudoaneurysm in the liver. In addition, she has bleeding from anastomosis region. So she passed embolization of splenic artery and stent graft to SMA artery to stop the bleeding. After 8 endovascular procedures in the time of post-operation period, she began to be with changes because anastomotic stricture in biliary jejunal anastomosis. And now, after 2.5 years, this is only one problem that she has, that permanent drainage in the liver. Next slide, please. You see very tight strictures. Next week, please. It's pre-dilatation with a 8-millimeter balloon. We had only 10-millimeter stent. So after pre-dilatation, the second, next one. Yeah, it's the implantation of stent, biliary stent. But in the time of the transplantation, through the 8th French introducer, the stent was broken from the balloon. And when we take the balloon out, we see the stent on the delivery of balloon. So we put stent next time on the balloon. And after scraping, additional scraping, we put the stent. Now you see the marker inside. And after the opening balloon, this is the time of opening the balloon, you see the tight stricture in the time of the delivery. You do it very slowly. Is fully opened. And this is final results. You see markers inside. A very good final result. Additional time, I want to say that this stent, it's not a metallic stent. So we must remember that he must be maybe very damaged in the time that we touch it and we put it inside. I prefer to do it through the sheath more than 8 millimeter, because usually our patients after the biliary drainage with 10 French biliary catheter, so we have no any problem to put 9-10 millimeter introducer sheath to prepare damage of the stent inside. It's finally with final results.
Thank you, Dr. Belenki, very much. This was definitely a very interesting case. The patient had been through quite a lot in the past couple of years, as you described it, and hopefully this will give her kind of a solution that will help her a bit and kind of ease her life and improve her lifestyle for the moment. And obviously we wish her good health. Thank you very much for taking these chances and joining us at these first experiences, and having these first cases within your hospitals. Both Professor Bloom and Adassa, Dr. Belenki and Dr. Bendot and Bellinson, we very much appreciate you for willing to try this new technology, and we do hope that this will give better answers and better solutions for these very unfortunate patients that went through a lot. I have my co-team Lotan here. She wants to say a few words. I'm just going to switch over the camera to her.
Hi everyone. Just to add thanks to Hadassah and Bellinson. It was lovely to work with you on these procedures, and it was very exciting. And it was very welcoming to come to your cath lab. So thank you very much. And I will hope to see you all in better times and healthy times. Any questions, by the way?
Feel free to unmute yourself if you want. Yes.
Yeah, I have a question.
Go ahead.
Hello.
Yes, go
Yeah,
ahead.
sure, go ahead.
Hi, it's Eliata from Bellinson. I'm sorry I couldn't see the procedure yesterday. My question is, do you see the stent at all while delivering it to the place, or if it feels, or if it moves from the balloon while advancing the stent to the location you want? Can you see it?
So what you have are 6 markers, because 2 are on the balloons and 4 are on the stent at the extremities, of course. The stent is absolutely not visible because it's not made of chromocobaltum or steel. It's made of, it's a different concept. It looks alike when you see it outside, but inside is almost invisible. That's why we have the 4 markers on the stent and the 2 on balloons to support you to place the stent, to land in the right area. And then you make the last check with contrast media, and you can see the duct that is open, and you can more or less see the stent.
But you can see the markers, the 4 markers, you can see it while advancing the stent to the position.
Yes. The 4 markers of the stent and the 2 of the balloons.
Yeah. Okay. Thank you.
Okay. If there are any other last remarks or last questions, we're here for you as well. If there are any future questions that you want us to pass through, Fabrizio here was delightful to have with us and escort us through these 3 procedures. It was very nice to have somebody so professional to have and answer the questions down the road. So he's with us to the future as well. If we have any specific questions that you would like to send through to him, he's at our service for that. And I want to thank him as well for attending this week with us. As much as difficult it is to get into Israel, we have you safe travels back home. And again, thank you all for being with us, and we hope for healthy times and new technologies to share with you guys. So thank you very much.
Thank you. Thank you very much.
Have a great weekend.
Thank you.
Thank you very much.
Thank you.
Bye.
Bye.